Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. So, in this video, I will be going over details on glucose-6-phosphate dehydrogenase enzyme deficiency. As you know, glucose-6-phosphate dehydrogenase enzyme is the most regulated enzyme in pentose phosphate pathway reaction that we have seen in the previous lecture. So, deficiency of glucose-6-phosphate dehydrogenase is the most common cause for hemolytic anemia leading to severe hemolysis. So, let's get into the details of this particular disease. Now, glucose-6-phosphate dehydrogenase deficiency, simply sometimes said as G6PD deficiency. It is the most common enzyme deficiency in humans leading to hemolytic anemia. So, the hemolytic anemia, the most common cause for hemolytic anemia is especially the enzyme deficiency induced hemolytic anemia. The most common cause is glucose-6-phosphate dehydrogenase enzyme deficiency. And it's an X-linked recessive disorder. That means males are the ones that are symptomatic and females act as carriers here. And G6PD deficiency is commonly seen in people who are descendants of African, Middle Eastern and South Asian descent. So, that means this particular disorder is by population genetics, it is kind of more frequent in this particular geographical area, that is Africa, Middle East and South Asia. So, as I already told you, affected are males and females act as a carrier because females have two X chromosomes. So, if one X chromosome is defective, other X chromosome will take care of the amount of glucose-6-phosphate dehydrogenase that need to be synthesized. Usually they act as carrier, whereas males have got only one X chromosome, and if that X chromosome is defective, they will suffer from severe deficiency of glucose-6-phosphate dehydrogenase enzyme. Now, note that it is a G6PD deficiency. It's not complete absence of G6PD. That means some amount of glucose-6-phosphate dehydrogenase enzyme is still present in these patients, and that will maintain or that will conduct an oxidative phase of pentose phosphate pathway and will make necessary NADPH plus to maintain the basal metabolic needs of the cell. Now, whenever there is an increased demand for NADPH plus because of so many triggering events, at that time these patients becomes symptomatic. So, that means glucose-6-phosphate dehydrogenase enzyme deficiency patients, they are usually asymptomatic, but whenever there is a triggering event which will lead to increased generation of reactive oxygen species, at that time there will be increased demand for NADPH plus, and if that demand is not met, and that will lead to severe hemolysis in them, and that makes them being symptomatic. So, what are the triggering events that will lead to increased generation of reactive oxygen species and thereby makes glucose-6-phosphate dehydrogenase deficient patients symptomatic because of severe hemolysis? And that is, if a person with G6PD deficiency suffer from any infection, that will trigger the condition, or if they are taking anti-malarial drugs like primaquine, pamaquine, so this kind of anti-malarial drugs may also lead to triggering of the disease, making a patient being symptomatic. Sulfonamides like sulfamethoxazole, so that will also lead to triggering of the disease, leading to making a patient being symptomatic. Certain analgesics like aspirin intake or thiazosulfone, methylene blue chemical, naphthalene chemical, or non-sulfa antibiotics like nalidixic acid, nitrofurantoin, isoniazid, dapsone, ferrazolidone, all these drugs, whenever a person takes these drugs for whatever the reason, if that person is already glucose-6-phosphate dehydrogenase enzyme deficient, at that time person becomes symptomatic. Okay, you got to remember all these triggering events, and that will be given in the exam, especially in the case stem. That's how the case stem starts. So, make sure you know that males are the ones which are affected here because glucose-6-phosphate dehydrogenase deficiency, it's an X-linked recessive condition, And also you need to look at the geographical area, that is African, Middle Eastern and South Asian. And also you got to look for what is the triggering event that has led to severe hemolysis in these patients. Okay. Now, RBCs in G6PD deficient patients are more susceptible for oxidative damage because patients with glucose-6-phosphate dehydrogenase deficiency already they have less than normal amount of NADPH plus H plus. So, if they have less NADPH H plus, that means they will have relatively less GSH, that is a reduced glutathione is less. If there is a less reduced glutathione, that means they will have higher amounts of hydrogen peroxide. And this higher amount of hydrogen peroxide in turn it will lead to higher hydroxyl radical formation, which is a reactive oxygen species. And what this reactive oxygen species does, this reactive oxygen species it leads to RBC lysis because it's going to damage the red blood cell membrane, thereby red blood cell membrane will break open and hemoglobin will come out and leading to loss of hemoglobin that leads to anemia. So in fact it leads to severe hemolytic anemia, and the hemolysis begins 24 to 72 hours after exposure to oxidative stress or any triggering event that we have seen in the previous slide. Alright, so the patients with glucose-6-phosphate dehydrogenase deficiency, they will manifest with weakness because of lack of hemoglobin leading to decreased oxygen carrying capacity. Tachycardia, so tachycardia is because of again decrease in hemoglobin content, lack of oxygen. So there is increased heart rate that will be going on, and because of the breakdown of hemoglobin, heme is broken down into bilirubin. So excess bilirubin will lead to jaundice. So patient presents with jaundice and presence of hemoglobin in the urine, so leading to hematuria. All these signs patient will show upon exposure to triggering event or triggering agent that leads to elevated levels of hydroxyl radical, which is coming from hydrogen peroxide. And also there is something called as favism. So favism is hemolytic response to consumption of broad beans or fava beans, and that is seen in patients with glucose-6-phosphate dehydrogenase deficiency. So already if the patient is having glucose-6-phosphate dehydrogenase deficiency, and if the patient consumes fava beans, which will release more and more oxygen radicals, and that will lead to hemolytic crisis. And also note that glucose-6-phosphate dehydrogenase deficient patients, they are protected from severe malaria. And that's because malaria, it will thrive in red blood cells. So RBCs, that's where malarial parasite will make their progeny, it will divide in the red blood cell. And glucose-6-phosphate dehydrogenase deficient patients, since they have less GSH level, their RBC membranes will be undergoing lipid peroxidation, because hydroxyl radical will break the which will lead to lipid peroxidation in the red blood cell, and there will be constant RBC lysis, although not at a severe rate, but there will be death of RBCs. So RBC lifespan in glucose-6-phosphate dehydrogenase deficient patient, instead of normal 120 days, it will be reduced almost to 20 days. So that means there will be rapid lysis of red blood cell in these patients, and that will make unfavorable environment for malarial parasite to thrive in the red blood cell. That's why severity of malaria, it will decrease in glucose-6-phosphate dehydrogenase deficient patient, and this kind of less severe malaria that is seen in G6PD deficient patient, it's kind of advantage for these patients having G6PD deficiency, which are protected against severe malaria. That concept we call it as heterozygote advantage. So just have an idea about it. So the figure here, it is showing you the overview of G6PD deficiency and the signs and symptoms that are seen in G6PD deficiency, how exactly hemolysis is going on. So let's start from glucose here. Glucose entering into the cell, converted to glucose-6-phosphate. Remember, we are looking at red blood cell here. This is RBC. Figure all this entire reaction shown in the red blood cell. Now the glucose-6-phosphate is diverted into pyruvate formation, glycolysis, and pyruvate to lactate, ATP generation. That's on one side. Some of the glucose-6-phosphate is diverted into pentose phosphate pathway, that is done by glucose-6-phosphate dehydrogenase enzyme and making NADPH plus H plus. And this NADPH plus, it is used by glutathione reductase enzyme and converting GSSG back into GSH, and that's a reduced glutathione. And this reduced glutathione, which is used by glutathione peroxidase enzyme, and it is going to convert hydrogen peroxide into water molecule, thereby it will prevent free radical generation. So use of GSH, so this content amount of GSH should be maintained at normal concentration so that hydrogen peroxide can be controlled, it can be neutralized to water molecule, and that needs sufficient NADPH, and that needs activity of glucose-6-phosphate dehydrogenase enzyme. So patients with the G6PD deficiency, as it is shown here, which I already explained to you earlier, if there is a G6PD deficiency, that will lead to decrease in NADPH plus H plus, and that will in turn lead to decrease in GSH. When the GSH is decreased, that means the activity of glutathione peroxidase will also decrease, and that will lead to increase in hydrogen peroxide. Note that hydrogen peroxide can be increased whenever there is a oxidative stress there. So increase in hydrogen peroxide means increase in hydroxyl radical, and that hydroxyl radical lead to increase in lipid peroxidation of red blood cell membranes, or red blood cell break open, and leading to hemolysis. Hemoglobin is lost, leading to severe hemolytic anemia. This is the mechanism of hemolysis in G6PD deficient patients. Now, G6PD deficiency can be divided into 4 types. That is a G6PD A plus variant, and G6PD A plus variant means these patients they have a relatively sufficient glucose-6-phosphate dehydrogenase enzyme, and usually they don't show any signs of severe hemolysis. Now, G6PD A minus variants are the deficiency of G6PD is significant here, and these patients will show hemolysis upon any triggering event that we have seen. Now, G6PD Mediterranean variant. G6PD Mediterranean variant is, it's a G6PD A minus that is seen in Mediterranean region, and usually it is severe form. Whereas G6PD A minus variant is seen in all, like African, Middle Eastern, South Asian, whereas G6PD A minus Mediterranean is specifically seen in Mediterranean people, and also it is more severe than other variant, that is G6PD A minus variant, which is seen in South Asian, African, and Middle Eastern region. So now fava-bean hemolysis. Now the fava-bean hemolysis is, it is the G6PD A minus Mediterranean variant. These people showing high sensitivity for the consumption of fava beans, leading to severe hemolysis followed by consumption of fava beans. Favism basically, which is seen in G6PD A minus Mediterranean, is simply put it as fava bean hemolysis. Now, coming to diagnosis of G6PD deficiency. Now, diagnosis of G6PD deficiency, we'll have to look at the ethnic group, like which type of people are showing hemolytic crisis upon triggering event. So like African, Middle Eastern, South Asian people showing hemolytic crisis or hemolytic response upon consumption of fava beans, or upon exposure to infection, or upon exposure to certain drugs and chemicals where hemolysis will be going on. So that type of classic history we'll have to look into whenever we deal with hemolytic crisis or hemolysis followed by sudden infection and triggering events. And then complete blood count and reticulocyte count, it helps in the diagnosis process. Liver enzymes, fractionated bilirubin levels are generally done. Lactate dehydrogenase to assess severity of hemolysis is done. Haptoglobin is it will bind with hemoglobin molecule, so haptoglobin hemoglobin complex. So higher levels of haptoglobin means less hemoglobin being available in the blood, or less hemolysis, and less haptoglobin means there is a severe hemolysis going on. And also direct antiglobin test, which is called as Combs test, it will differentiate immune mediated hemolysis than non-immune mediated hemolysis. So in order to differentiate that, so Combs test is done. Now, one of the important feature of glucose-6-phosphate dehydrogenase deficiency that we must look at is Heinz bodies. Heinz bodies can be seen in red blood cells on blood film, and Ionge bodies are also referred as bite cells or degmocytes. These are precipitated hemoglobin molecules because of the effect of reactive oxygen species on hemoglobin. So the precipitated hemoglobin molecules in the peripheral blood smear which are seen referred as Ionge bodies or bite cells or degmocytes. So this is the characteristic feature of glucose-6-phosphate dehydrogenase deficiency that we must be looking for. So, and then we have Butler fluorescence spot test. Butler fluorescent spot test, it will visually detect the amount of NADPH plus present in the cytoplasm. That means lack of or decreased amount of NADPH plus, it will decrease a lack of fluorescence. So that's one of the use of doing Butler fluorescence spot test. And then spectrophotometric analysis of G6PD activity can be done. That means basically we are directly measuring the activity of glucose-6-phosphate dehydrogenase enzyme. So these are all the diagnostic tests that we can use to diagnose G6PD deficiency, including family history and then any triggering events that you will have to look for, and then complete blood count, liver enzymes, and then the bilirubin estimation, haptoglobin estimation, and also we are doing Butler fluorescence spot test. So variety of tests, and then Ionge bodies, bite cells, degmocytes. So all this will help in our diagnosis process. So that's all about glucose-6-phosphate dehydrogenase enzyme deficiency. Thank you.